Good morning, everyone. Ralph, please. Good morning. We're going to start our session, the first session in the morning, on innovations versus evidence, the challenge of new bariatric techniques. We're moderating here with Francesco Papadia and Nicola Di Lorenzo. And the first speaker, we have a change we're going to change the order because Ralph has another commitment now. And Ralph will speak on the ethical challenges in metabolic bariatric surgery innovation. How to protect the patients. Please, Ralph.
Thank you, Ricardo. Good morning, everybody. Yeah, I have to go to prepare next year's meeting in Munich, so that we will be all happy then. We have to prepare it. These are my disclosures. I mean, key aspects of ethics in surgery in general, they need an informed consent, every patient. I mean, that is basics, but still, you have to inform, even if you do an innovative procedure, you have to inform even much more. And you must respect the, these mics sometimes are intriguing. You must respect the patient's right to accept or refuse, even though you are convinced that this new innovative procedure is going to make him very, very happy. And you have to balance healing against causing bodily harm. You have to avoid that. I mean, it's basics, but still, sometimes we forget that. And the obligation also that the surgeon prioritizes the patient's well-being over self-interest in proving I have done one more of the patellary procedure. And then it is very difficult if the basic knowledge is not there, if that procedure is really good, if you don't know all the early and late complications. So in innovation, the patient really must know that he undergoes an experiment. And I think this is something we do not do all the time. What makes a procedure better? I mean, it leads to more weight loss. In the majority of patients, very few non-responders, it's durable, low rate of excessive weight loss, because that's also something that we produce many times in some procedures in the long run that has a good and strong metabolic effect. And it's also very important to know why it works. We don't know everything, but we must go into details why a procedure works, and this helps also to find new targets for medications and stuff. It has to be safe, it has to lead to a good quality of life. If it's reversible, I think that's a good factor for a good procedure. It has also economically, if it's less expensive, that is worthwhile pushing forward a procedure like that. And if it's easy to perform and also to perform by non-surgeons who are as the experts level like the inventor of the procedure, and it also has to be easy to teach. So how can we improve an existing procedure, or how can we develop a new one? That's the major question. And we always have to take into account what the price will be that the patient has to pay early on, but also in the long run. And the long run is something that is more important than you might think. So what have been in the history of new procedures? I mean, there was a time they did horizontal gastroplasties. I think this time was not very long, because we can imagine that this is not going to work, because this little stoma at the greater curvature didn't work. Could they have known? Well, now we can say yes, but at the time maybe they tried it. I don't know if the patients really signed an informed consent that that time they underwent an experiment. And then this whole story about distal gastric bypass with a very, very long alimentary limb and a short common limb. We have had 2 series in Switzerland. I don't want to blame anybody, but they have had nice weight loss results. But we inherit now, 20 years after that has been performed on patients with a BMI of 35.3, this extremely hypoabsorptive procedure with terrible nutritional deficits. And we saw that picture of that lady with their hands yesterday in this very nice, funny session we had here. So the malabsorption, or even the liver issues we had a large number of patients with really strong liver cirrhosis and also oxalate nephropathy and all that. So could they have known before? I think yes. You don't do such an aggressive procedure in somebody with a very low BMI. But it's out. Then we all, or most of us, the older ones, went through gastric banding. Did we have an animal model? I don't think so. Did we have ethical approval at the time when we started doing that? No, we just taught ourselves. We developed that procedure at the time. Early on, it was safe, but in the long run, in our series, we only had 12% good and sufficient results. It's too low. Could we have known before? I don't know. Probably yes, but at least we learned how to do these procedures laparoscopically in an easy operation. If we had started like others with a bypass, we would have had maybe other people suffering from that experiment. But then I saw in 2001 a presentation where somebody introduced his own new band, but when he tried to inflate the band, the balloon was on the outside instead of the inside. And I mean, that was not an animal that we saw, it was a human we saw. And I thought, boo, did they have an ethical approval for that? I don't think so. But they were courageous enough to show that to us at that time. And then the history of ghrelin reduction surgery. I mean, yeah, could they just resect the fundus in addition, so they think they do reduce 85% of the ghrelin-producing surface of the stomach? It does not work because the EEC of the small bowel will take over the ghrelin production, but they could have read the papers that showed that before, but they still did it. And I mean, I'm not against resecting stuff that has to be taken away. If you have a rotten stomach, you have to take it away. That's all good, but not a healthy stomach for a result that is expected not to work. Then the story of the BPD. I mean, Nicola did have an animal model. He did follow up his patients, and Francesco did this very nice 30-year result paper. We have our up to 20-year result paper on BPDDS, so it is a very long-lasting weight loss procedure, but we had 40 patients to revise for nutritional issues, for other problems we had. And the similar thing is malnutrition, 30 years down the road, is more than 70%, but that led to the development of a newer procedure, the SARDS, which is actually probably a safer operation than the BPD, and so you can change also existing procedures. And now we have endoscopic procedures. I don't want to judge too much about it, but it's difficult, in my opinion, to make a wrinkled stomach and claiming that the fundus has to stay there because that causes satiety. Very weird concepts. And are they really better than OMMs? I don't know. And in Switzerland, it's only allowed in trials after ethical approval for the moment. We don't need new cowboys around. And I don't go into this topic where food has to decide if I go left or right. I want to see the animal models. I want to see nicely designed RCTs showing that this is worthwhile doing. I don't want to blame anybody, but I think this is a strange concept. We have a success story, the standard Roux-en-Y gastric bypass for more than 60 years now, and it's just a sustainable long-term weight loss, and we should always compare everything to that, but the bypass is not perfect for everybody, so you can try to improve the bypass. We have this multi-center trial in Switzerland. On our way, we closed it 2 years ago, are analyzing now the 1-year results, and we did have, we compared 2 different BP limbs and knowing the total body length. And just to show you, we had an animal model. Romano Schneider really did operations under the microscope with these mice, and they survived. But then the ones with a very long BP limb, this doesn't work anymore, with a very long BP limb had to be euthanized because they were just starving. So there is a limit to what we do. An animal model can help. So if we invent a new drug, we go through different stages. And obviously, we cannot transform all these different phases of research for surgery, but actually we should go through a similar concept, and especially phase 4. Here is where long follow-up cohort trials will show if these very selected patient groups in RCTs really do the job in the real world. And They have that too in pharmacotherapy. We should also have that. So evidence is clear. RCTs, matched pair analysis, and all these different sorts of trials can be performed. They have their advantages and disadvantages. I do not trust always the evidence-based level that only RCTs are the real world or the real truth, but sometimes you have to be careful in making assumptions. If you have a strong correlation between two biological facts, so the rate of storks flying over southern Sweden in the year 67 compared to 68 is highly correlated with the birth rate of Paris in the same year. And it's just not a causation, or maybe you challenge this, but I don't believe that there's a causal linkage between these two facts. And this is something we forget sometimes by analyzing our data. So that's why we do need animal models for something. So again, coming back to the patient, we have to be careful. It's just a mini bypass, and it is just lying. The patient coming from somewhere else with a mini bypass, OAGB, of course I should not call it myself mini bypass, with an OAGB with a BP limb or afferent limb of 4 meters in a BMI of 33. I mean, how can you do that? And it's just a mini. And so, and then this claim that we just go to the mouth. No scars, no visible scars. If you have an ESG, your stomach has scars, and we don't need surgery. I've done that hundreds of times. I'm the inventor of this procedure. So we have surgeons, at least in Switzerland, we have some of them that are really influencing the patient, and this is dangerous. So in summary, MBS is a playground for pioneers. Pioneers is good, but no cowboys, please. And I don't want to be I did mistakes in the past. I did weird things. I was lucky enough not to get punished for it, but so it's not just blaming others, but we have to learn from these experiences. And you have to do research if you want to prove that your new operation or your new procedure is as good as others. And you have to compare it, in my opinion, always to the bypass, and to have a clear research concept, also according to ethical standards. And the patient, again, must know that he's undergoing an experiment. I think that is important. We must find new multimodal therapeutic concepts in the treatment of severe obesity to define predictors of outcome for the various modalities. In Switzerland, our research official research foundation did not sponsor a trial comparing tirzepatide versus bariatric surgery because they say it's enough data around. They did not fund it. But we have to fund it, such kind of trials, to really know who's a good candidate for medication and who's a good candidate for surgery. And so we should not do long-term harm and make it available for more patients in need. So thank you very much.
Thank you. Thank you, Ralph. What do you advise to surgeons who jump into new procedures because they fear of missing out something very new and this will change the world?
Well, open evidence is a good source to go and check if somebody has already done it and if there is evidence that this idea might work. And just take somebody with you who is a bit wiser and not pushy enough too much to really be careful. And respect the individual. I mean, it sounds so pathetic, but I think we just lose it if we want to prove. I mean, I wanted to prove that bands are good. That's why how I started, and that is dangerous.
No questions for you.
No more questions, okay.
Thank you.
Thank you.
Now we continue on this stream. I think that it's not very popular what we say because most people like to have 1 centimeter anastomosis aside to give its own name to the procedure. But I think that Francesco Papadia will be very straightforward in saying that innovation in bariatric surgery, if we are moving too fast. Please, Francesco.
Okay, thank you very much. The title of my talk is about innovation in bariatric surgery and whether we're moving too fast or not. I have nothing to disclose. Now, I do have something to disclose, and this is my unofficial disclosure slides. This talk is going to be controversial. Please do not feel offended, and I really don't want to single out the individual surgeons. I just want to raise awareness about what I perceive, and it's not only myself, to be a problem. Now, as we all know, in the 90s, bariatric surgery has encountered a perfect storm that had made it balloon in numbers. So this storm was driven actually by laparoscopy and by an innovation, which was the gastric banding, which popularized metabolic bariatric surgery. And from being a niche part of the surgical field to being really mainstream. Now, up until today, no single operation has demonstrated a clear superiority over the others. And there has always been the need to investigate, to simplify, to perfect each operation with minor or major variation of technique. Let's think about the introduction of laparoscopy and how the introduction of laparoscopy has changed, for instance, the technique of gastric bypass, or the introduction of sleeve gastrectomy, at first as a two-stage duodenal switch, and then as a single standing and a standalone procedure. On top of that, the discovery that metabolic bariatric surgery had independent metabolic effects had led to even more interest in investigating the procedures to see if the same metabolic effect could be achieved with less side effects, less comorbidities, and maybe even less without weight loss. Now, surprisingly, up to today, there is very little long-term results on patient data on patients submitted to bariatric surgery, even for mainstream operations. And so this raises really the question, can we really draw a line between a mainstream operation with a technical variation? And when does the technical variation become a new operation, an experimental, let's say, operation? And how can we handle operation? What has happened up until now? Now, we did a systematic review to identify and characterize non-standard primary bariatric surgical procedures involving intestinal anatomical modifications. We examined the reporting patterns for these procedures, including the duration between the first human operation and its initial publication, the size of the initial patient cohorts, and the follow-up consistency of the single procedures. And then we evaluated also the adherence to ethical standards, specifically regarding the presence or absence of institutional review board approval, clinical trial registration, and reporting on patient safety outcomes. So it's a systematic review performed as usual for different publicly available databases with basically the main keywords. It's much more complicated than that. You can access the full search protocol on Prospero. It's registered. Primary surgical and modification of intestinal analysis. And then we did this quantitative analysis. Date of the first operation, a year the technique was published first, and the time spent between, the number of operated patients presented in the index operation, the presence or absence of any follow-up operations of that, the number of centers performing the new technique, and the total number of the patients submitted to the novel procedure. Now, on top of that, we tried to analyze with different scoring systems the quality of the data that came out of these different studies using 3 different scales. And I'm not going to dwell too much into that, but basically these scores try to analyze whether there is a bias in reporting or a bias in selection, if there is a comparative arm as well, just to scale, to give a point whether about the quality of these studies. Now, the study is registered, and the search period was from January 1st, 2000 to December 21st, 2004. All the studies that we retrieved, we then analyzed and did the ballooning, snowballing of references, checking the reference list in each paper just to check out that we didn't miss any other. And in the end, we identified 57 papers starting from 2002 to 2024 with a median interval between the surgery and the first publication of 5 years. We've ranged from 0, which is pretty acceptable, to 25, which clearly is not. The mean number of operated patients in the index publication was 39, again ranging from 1, which is okay, acceptable, to over 1,000, which clearly is not. Including the follow-up papers, over 10,000 patients have been reported in these studies. And this comprises different kind of operations, like combination of gastric surgery, including jejunal ileal bypass, or modified jejunal ileal bypass, sleeve gastrectomy with enterectomy, isolated transverse partition with or without sleeve gastrectomy, and sleeve gastrectomy with ileal interposition. In most cases, the novel procedure was performed in only one center. In 10 cases, no mention of IRB approval could be found. In one case, IRB approval post-dated the first surgery. Registration in a clinical trial database could be traced only in 6 cases, that's roughly 10% of identified studies. And median follow-up was less than 2 years, ranging from 0 to 8 years. So, as said, including the follow-up publications, over 10,000 patients were operated. Now, if we see the quality scale of the different studies, we can see that only one study was identified as a high-quality study according to the Newcastle Ottawa scale, and not a single study reported the loss to follow-up. Not a single study reported the loss to follow-up. According to Joanna Briggs Institute scale, most of the studies failed to use standards objective criteria to identify success or failure. And again, the risk of bias due to confounding was extremely prevalent in most studies. So the bottom line, those tools came to the same conclusion. The evidence that was produced from these studies was uniformly weak and a high risk of bias. Now, let me cite from the medical medicine. We all know Dr. Alfred Blalock, the father of the first treatment of blue babies, and he said that it usually requires a considerable time to determine with certainty the virtues of a new method of treatment, and usually still longer to ascertain the harmful effects. Or Mark Ravitch, who is one of the fathers of pediatric surgery, who used to say that if a technique had already been reported adequately, but then was not persistently followed up by its creators, the conclusion may be safely drawn that the procedure was defective or unattractive. Now, actually, we have a framework on how to introduce innovation in surgery, and that's called the IDEAL framework, which was published 15 years ago in the British Journal of Surgery. So you start with the idea, okay, and a very small series of cases, 1, 2 pilot cases. Then you go over to the development phase, where you do small series of maybe 10, 15 cases, 20 cases, maybe few more in 1 or 2 centers. Then you go to phase 2B, the exploration, possibly with a prospective and multicentric study. Then you go to the assessment phase, and finally to the long-term study. And a mandatory prospective registration is required from phase 2B onwards. Now, in our systematic review, there was a systemic failure in this kind of governance and in this approach. The IDEAL framework has completely collapsed. We had delayed and weak evidence, 5 years median delay from the first surgery to the first publication. 26% of the studies had a follow-up of more than 3 years, and only 14% of more than 5 years. The majority of studies had a low quality, according to our scales, and a serious risk of bias. And that has led to a massive oversight gap. Over 10,000 patients have undergone already these new operations outside of a clearly defined framework, and only 11% reported clinical trial registration. And a substantial number completely failed to report any kind of IRB approval. So the innovation has led directly into the clinical phase, bypassing completely all the supervision. Now, This is a call for some structural and cultural change for surgeons and societies. Let's move beyond statements. Let's really adopt the ideal framework as a mandatory pathway. For journals, and here we have a very prominent editor, prospective trial, who agrees completely with me. He's one of the authors of this paper. The prospective trial registration is mandatory and non-negotiable for publication of a study. And for the field, we have to maintain credibility, especially in an era where pharma is doing excellent, very high quality, very rigorous studies on pharma. We cannot simply afford to put out this kind of evidence. It's not good for us and our field. We're losing credibility. Thank you for your patience and your attention.
Thank you, Francesco. Any question for this nasty speaker that gave us some data which I think are not to be discussed in terms of general consideration, but I'm pretty sure that Marco Butter have some comment.
Francesco, congratulations to this work. This is really important to be done to show around, where the mistakes are. You focus predominantly on metabolic bariatric surgery, and I ask myself whether that is a metabolic bariatric specific problem, or do you think this is a wider problem for the surgical community, or even for the medical community in general? Can you comment on that?
I have a very...
Sorry to ask that question.
No, that's an excellent question. Actually, I have a very good example from the Deutsche Gesellschaft für Chirurgie, for the German Surgical Society in the mid of the 80s with Erich Mühe. Now, the German disclaimer, I've been educated by Germans. I have attended a German school and then I'm Germanophile. So that's my other disclaimer. So the German Surgical Society has been indicated as the bad guy in the story because it's castrated innovation, punishing Erich Mühe when he presented his first laparoscopic cholecystectomy. He presented 94 cases at the, I think, 1986 or 87 meeting of a German society. So bad Germans, stuffy people with no ambition. Actually, the surgeon, Mühe was right. The operation was right. But the society was also right because it probably felt that this kind of innovation should have undergone a more rigorous testing. Regarding metabolic and bariatric surgery, I think, unfortunately, and I think it lies to stigma. Stigma for the patient with obesity. We have dared to treat some of our patients differently than we would have treated them if they had another illness. That's my very, very...
Yeah, but I think you're right. The other fields of surgery are undergoing innovations without proofs. However, I think the metabolic bariatric surgeons are undergoing an identity crisis. My volume is going down. The drugs are improving. The drugs are published in JAMA, New England Journal, wherever, Nature Medicine. And I hear all the time, I need to innovate because drugs are getting newer and more powerful. If I don't do new operations, I'll lose my patients. So I hear this all the time worldwide. So I think despite, I ask colorectal surgeons, I ask general surgeons, thoracic surgeons, yes, they have their outliers doing crazy things. However, in our field, it's all because we are here, but in our field, the pressure of, I want to be the pioneer because I'm an innovator, I'm Galileo Galilei. So I need to move forward and quick, otherwise the drugs will swallow me. So I think the feeling of the surgeons is metabolic surgeons is different than the other general surgeons.
Well, if I, am allowed to comment on that, which I'm already doing right now. The pressure of the pharmacotherapies is rather recently, if you look at the history of metabolic bariatric surgery, right? And many of the procedures that you did not necessarily mention, but that you indirectly criticize, were developed in a phase where with nothing else than bariatric surgery. Basically, there was no pressure to develop, at least, let's say, over the last 2 decades, because we had operations that already worked. When the gastric bypass procedure was introduced, there was nothing to treat diabetes. So there was room and some sort of necessity for pioneer to.
But go ahead.
And you know, the conclusion that now under the pressure with alternative therapies, we need to be innovative, in my opinion, is absolutely the wrong conclusion. You know, we need to be better, we need to be more detailed
Safer.
about the procedures that we do have. And I am echoing what Francesco was saying, you know,
Yeah, but I have a counter
because we are
argument.
going to be compared to studies that is being done by pharmacotherapies, which have millions and millions of money.
Francesco
to put
didn't
into it.
mention, but I'll mention in my presentation. When the operation was invented, they took at least 5 years to report it. And if you look to the 5 years is when the second generations of GLP-1s arrived in the market. And 25% were reported 8 years after. So this delay, it's because I'm a genius, so I'm doing the operations in my poor patients, but now the drugs are here. I'm going to publish this. I'm going to publish because I'm going to revolutionize all metabolic surgery. So this delay matches with the new generation of drugs.
Yeah, I see.
I can add a couple of things which are related to this. Remember, I used the slide. In 2018, there was a conference in India about, you remember, the poster was made of all the pictures of the procedures, and now they are even doubled probably for standardization. So that, as you said, the problem is raised maybe 2 decades ago. This is one. The other story, because I was, together with Gianfranco Silecchia, the proponent of the IFSO EC EIS guidelines published in 2020, 2021, the worst thing that we found with the GRACE system, which is now currently used, but at that time was not by everyone in guidelines, was the lack of follow-up. This is another page is the same thing. The lack of follow-up is dramatic. Everybody reports that 2 years I have wonderful weight loss, diabetes, et cetera, et cetera. But the only data we have, I can say that Francesco is publishing the data of BPD at 50 years.
50
is it
years.
correct? This is by far outstanding, but all the others are published at least at 2-3 years. 5 years is already good. So I think we have a long ride to be better.
Thank you. Thank you, Francesco.
Thanks.
Marco, please. Marco will convince us that we're not doing enough first in humans, enough first in animals, but we're jumping into first in humans too quick. Please, Marco.
So thank you very much for that kind introduction and, you know, for creating that session, Francesco. You know, a very important session in my opinion. I was asked to look into the role of animal models to clinical trials and to answer the questions whether we're doing enough before we actually introduce new technologies in humans. And I also have a personal disclaimer. You know, I'm going to share my personal opinion. It may not surprise you that I'm rather skeptical that we do enough before we actually introduce new techniques into humans. And I would like to clarify that I'm not against innovation, not at all. I like innovation, but I disagree every now and then how new procedures are introduced into the system. Let's put it that way. I'm not against new procedures. And I would like to underline my point by looking back to a procedure that we all know, which is the gastric bypass, which was firstly introduced and reported nearly 60 years ago. First scientific report in 1967, which is quite a long time. Today it's fully established in the treatment of obesity, and many of us consider it even the golden standard in the treatment of obesity. And we all know, yes, it works. But if you take a closer look and you're critical about it, how does it work? Do we really know how it works? And for whom does it work? And even more importantly, for whom it doesn't work? So if I ask this room at this time of the day, what do you think? How does the Roux-en-Y gastric bypass procedure works? I would expect the following responses. One would be certainly restriction and a reduced meal size. Some of you would mention malabsorption or hyperabsorption and caloric loss of the ingested food. There is a role of rapid nutrient delivery to the distal intestine. We all know that gut hormones may play a significant role, or they do play a role, and mentioned in GLP-1, PYY, ghrelin, insulin, and glucagon changes, bile acids, FX receptor, and TGF-5 signaling. The gut microbiome has been a big thing a few years ago. Everyone started to collect stool samples of our patients and looking at what kind of bacteria were growing in there, hardly able to pronounce them correctly. Vagal and spinal afferent signaling, food preference, reward, aversion, changes in eating behavior, my big thing. I really like to investigate that. Energy expenditure, set point theory, defended body weight. And we all agree that all of them for themselves sound very plausible, and they are plausible, but none of these mechanisms is probably enough to explain what actually happens in the bypass surgery. And if you look at the data, and Ralph mentioned that earlier already, if you critically look at it and try to answer the question, what is association and what is really a causative effect, the number of papers that we can actually use to explain thoroughly the effects of the surgery, limits to a single-digit %, I would say. Which mechanisms are absolutely necessary, which are just secondary to weight loss? It's an important question, and has been answered with the gut hormones, and for the diabetic resolution after surgery. We know that the weight loss itself does play an important role. Yet many people still refer to weight loss independent mechanisms, which is partly true, but it's not black or white. It's always something in between. And which mechanisms are specific to a specific operation? So let's have a look and go back to the bypass operation. And I go back to the data from my former PhD supervisor and friend, Carl Leroux, which were published 20 years ago in the Annals of Surgery. You see two sets of data. On the top row, you see the human data, which is gut hormone levels of GLP-1 on the left and PYY on the right after a semi-liquid test meal. It was Häagen-Dazs ice cream back at the time for 400 kilocalories. And you see the black triangles are the PYY and GLP-1 levels in patients after gastric bypass surgery. The black squares are gastric banding patients. The white squares is lean patients, and the white circles is obese patients, unoperated. So these were the controls. Down there you see the animal data. These are PYY and GLP-1 levels in a different operation. This was a GIB, a jejunal ileal bypass, because back at the day it was hard to do a gastric bypass operation in rats. So it's not really the same operation, keep that in mind. And these are fasting levels. This is fasting levels in animals. On top you see postprandial levels, down there this is fasting levels. So there's a difference, right? But yet we concluded altogether that the bypass operation produced exaggerated postprandial PYY and GLP-1 responses in humans and rats, and the endocrine profile favored an anorectic state and improved metabolic parameters. 1 year later, a second set of data was published, and again, they compared, and I use this language because it was used in that paper. Nowadays, we're not allowed to use poor and good responders anymore, but this is, 20 years ago, this is what we used. And you could see differences between people that responded well to the surgery and people that responded less well to the surgery in terms of PYY and GLP-1 levels. This was, again, postprandially. And then they did something to suggest a causative effect of gut hormones. They tried to block it. Back at the day, there was no specific antibody for GLP-1 or PYY that was, anywhere being able to be used in humans. So yet they used somatostatin, which is octreotide, which is considered to be a dirty drug because it blocks literally everything in a human body which is related to hormones. However, if you do that in humans, you can see that you can increase the food intake by a pharmacological treatment. Conclusions were poor weight loss responders show attenuated PYY and GLP-1 responses, and the inhibition of gut hormone release increased appetite and food intake after bypass surgery. Fine. You know, that's a coherent and attractive bariatric narrative that's still around, and we still use it. Bypass increases gut hormones reduce appetite, gut hormones improve metabolism, therefore they drive the clinical effect. Fair point, you can do this. Nearly 15 years later, this paper came out, and this is just the result of a set of previous papers of Randy Seeley looking into, okay, how important are gut hormones? Indeed, this is a mouse model in which at the same time GLP-1 receptors and PYY receptors were knocked out. We all know the limitations of knockout models in mice, but they tell you something in a high-fat diet-induced obesity model and bypass surgery in mice. And to keep a long story short, you see that getting rid of GLP-1 and PYY receptors in mice has no effect on the cause of body weight in a mouse that undergoes bypass surgery compared to the wild-type mice. That's true for body weight causes, that's true for fat mass, that's true for lean mass, that's true for adiposity index, and that's even true for leptin levels, suggesting that PYY and GLP-1 alone may not be the story. So in conclusion, putting these mechanistic studies together, with somatostatin, we blocked everything. I think we proved something. I'm not necessarily sure that we understood everything. You can fill the gap yourself. And yet, and that's the important part, this story was used in that time between 2006 and 2019 to be translated into humans. Transit bipartition, iliotransposition, even endoscopic procedures were used in order, we know gut hormones are important, so we have to do something to increase the gut hormone levels in patients. We have to enhance distal gut signaling, which at that time was not totally unreasonable because it seemed to be a logical extension of the data we had. But to be fair, a set of operations and procedures were created, engineered around association. There was not even robust scientific evidence. It's just associations. It's like the stork story and baby story that Ralph Peterli showed. And we translate that into humans as a society. I'm not finger-picking anyone. We in the society, we all were sitting in the rooms when these data are presented and rarely stood up as we should have done. But this defines us as a society. If you look at other procedures, not only the bypass, but sleeve gastrectomy, the one-anastomosis gastric bypass, the RDS, the BPDDS, they're all effective. We can reproduce these effects, these clinical effects, we can do that. But I think it's fair to say that mechanistically, they're all incompletely understood. We don't really know what we're doing there. Clinical endpoints of studies tell us whether the operation worked. I think we're pretty good at that. We have lots of randomized clinical trials. We have a few retrospective analyses. But what I would like to call mechanistic phenotyping, which tells us why an operation works, and even more important, for whom it does not work, and at what biological cost. There's a huge gap that we not really fulfilled over the last, let's say, 60 years, since when the gastric bypass procedure was officially introduced. So what animal models can do, you can use sham surgery, which is hard to do in humans, so to analyze what is being caused by the operation itself. You can do pair feeding, body weight matching. You can use pharmacological antagonists or agonists. You can use knockout and receptor models. You can easily sample tissues from whatever you want, and you can, modify surgical variants. Animal models do certainly not answer all the questions, and there will always be a back and forth between human and animal data, but animal data can help to get an idea where to look closer in humans. You can do some stuff in humans with, different burdens for the patients. You can measure weight, body composition. I list them there with moderate burden. You can do mixed meal tests. But this is not only the moderate burden for the patients that actually participate in the studies, there's also a burden for the investigators, because don't make a mistake, this is all hard work. It's time consuming and it costs energy. And I don't think that every trial needs, everything. But I do believe that every new procedure should be investigated enough to explain its biological mechanisms, especially these days where we do not have this pressure to come up with new procedures. We do have procedures of which we know that they work. Let us understand how they work. So I would like to propose a practical standard for future surgical trials. I do believe that for every new procedures, we should try to answer 3 questions. Does it work? The next question should be, how does it work and for whom does it work? Responder biology, looking at complications, what is the nutritional risks, and how can we select patients based on, to make sure that each patient benefits maximally from what we offer them. Clinical trial design, in my opinion, should preserve mechanistic learning as deliberately as it preserves safety monitoring. I think this is, on the same level. We always discuss safety, but we also should discuss, okay, wait a minute, how does that work? So in summary, I think we all operate with confidence. I do think that our mechanistic understanding is less good. And yet, as a society, we keep innovating. So and before first in humans, I think we should know more than it works. And I would like to finish my talk with the quote of Václav Havel, who said that the tragedy of modern man is not that he knows less and less about the meaning of his own life, but that it bothers him less and less. And I think that's very true. And I would highlight, a recent activity that I start with Paulina. It's Obesity Podcast. The next episode will be released very soon, which will be with Ricardo and Francesco talking about, the Lancet Commission. And join us on social media. Thank you very much for your attention.
Thank you, Marco. I could not agree more. Actually, when I'm going to present, I'm going to summarize all of this, but you're totally right. We're trying to do right things.
Finally.
To the wrong path.
Yes.
So, yeah.
Do we have questions? I would add something that is point 3 of your final consideration, because you are speaking about phenotyping the procedure, but phenotyping the patient is something that we are far away from doing that. I remember a wonderful lecture by Rachel Batram years ago about phenotyping the patient, which of course in clinical stuff it's not easy to go in depth in a single patient. This could also a way to, once you have a safe procedure, a way to address why it works with some and why not. It's not only the mechanistic aspect, that how long the bowel is and so on, but it's also related to the specific patient. I understand that this is very theoretical, and we all know it because we have big numbers and it's difficult to do that. But also to improve this part, I think we are in a good situation, but we can do much better.
We still have time for one more comment, right? Because yes. What I usually get is a lot like, yeah, that's something I don't need to do. This is something for the academia, right? I'm not in academia. This is academia stuff. This is not my role. I could not disagree more, because we all, by definition, we all academics. You all finished, studies. You all finished university. By definition, we all academics. That's our job. And it's like doing the taxes. No one really likes that. It costs energy, but it's wise to do, to investigate and invest some thoughts into this, because you better make sure you're not paying too much. And I think it's the same level, Not everyone likes it the same. There are some nerds like us who, oh yeah, antibodies and gut hormones and mechanisms and behavior, that's great, isn't it? That's not for all. I fully get that. But I do think it's part of our job for all of us to at least twice a year dive into it and try to understand what's going on.
And if I can add another comment, if you're not academia, you can still ask for help from academia.
Of course, that's a fair point.
You can be associated with someone who is actually doing research. I totally understand that you don't have the facilities and you don't have a training and background for this kind of research. That's fine. That's not a problem.
Exactly.
Send a mail.
Yeah, and there's nothing...
I would like to investigate this. Can you help me out?
Yeah. Thank you.
Thanks. Now, thanks, Marco. And it's a pleasure to introduce Professor Ricardo Cohen, who in his talk will try to draw a line between what is innovation and what is variation, and trying to understand what is new, what can be considered new, what is too new to be considered. Where do we draw the line?
Thank you, Francesco. To be the last one in this session where all the speakers think alike is not an easy task. But I'll try to show my perspective on that. So those are my disclosures. And as all the speakers mentioned, innovation demands evaluation. So it's a no-brainer. But there's a paradox in innovation because people want to be the first. I want to be the first to do the butter operation. So I go quickly. But this disconnection of I want to be the first, or fearing of being missing innovations that will save the world, leads to premature adoption and mainly underreporting the harms of the intervention. What is the power of randomized controlled trials? If you look at the jejunal ileal bypass, it was widely adopted in the 50s, but I can understand in the 50s, post-Second World War, people didn't have the resources to do research. They didn't know the principles of research. They didn't care about mechanism, Marco. They wanted to do an operation to save lives. So the reality is that the operation was abandoned because of its complications. So the cost of innovation is to prematurely kill a lot of people. That's the point. And then some RCTs just prove the opposite that the common sense will tell. This is the Women's Health Initiative. It's an RCT where their endpoint was to prove that hormonal replacement therapy in menopausal women will protect them for cardiovascular events. And it proved the opposite, exact the opposite. People who take the hormonal replacement died more. The same with the ACCORD trial. Tight glycemic control had led to more mortality. So it was exactly the opposite of the truth. So, as the jejunal ileal bypass, those studies may generate hypotheses, but ideally RCTs for superiority claims, they really establish the value and protect our patients. What Francesco showed is a paper that it's in press at the British Journal of Surgery. And I'm going to quickly go over the data, but we had, as he showed, 57 studies on innovations, almost 11,000 patients, but they were a total failure in oversight. They exposed those 10,000 patients to an innovation without any proof of efficacy and safety. And as was mentioning to Marco, they delayed a median of 5 years after the discovery of the magical operation. And 25 of those studies led 8 or plus years. So this matches with the new GLP-1 era. So I had a fantastic Rubino operation. However, I'm going to delay it because when I feel the pressure of an innovation of a drug, I'll publish this. And I'll publish this in some different journals. And there's an illusion of success because if we look at the data that we collected in that systematic review, 98%, so almost all of the papers evaluated carry a high risk of bias, as Francesco showed with the tools that we used. So the risk of bias was enormous. And 90% almost of the procedures were introduced without any prospective registration. And look at this comment from the editor-in-chief of The Lancet back in 1996. Surgical research or comic opera? Questions and a few answers. So one of his conclusions was biased studies may look convincing in numbers. Yes, they are. We have 10,000 patients. But they add little to science. Just to say, they add nothing to science. And yes, there is the ideal framework, and it's totally ignored. Somebody has an idea, they develop the idea first in human, and all the other steps were simply bypassed. The exploration, the assessment, the long-term studies, I don't care. Why? Because I have the pioneer mentality. surgeons could be rewarded to be the first one and to have their name tagged into that innovation. Second, maybe some financial incentives from the industries, not mentioning names, but profits of advertising an operation and without any proof of its efficacy and safety, I don't know. Academic pressure, I want to pile up publications because my tenure at the university demands me to publish. So publish or perish, so I publish anything I want to have papers to move on in my academic career. And the identity crisis after the effective obesity management medications. So I fear of losing my patients to the new drugs or endoscopy or whatever, so I move fast. But we need to look at the outcomes that really define the clinical value. Defining weight loss of 42% in 1 year, so what? It's a chronic and progressive disease. So what I need to know is sustained weight loss, glycemic control, blood pressure control, MASH resolution, microvascular complications, cardiovascular events. This is what we need to look for. And we have established operations like the sleeve and the bypass. The new approved quotes operations like the SADIES and the OAGB, they don't have those outcomes published so far. Nothing. So we have 12 randomized controlled trials where we prove that surgery is effective and safe regarding the glycemic remission. We have a randomized controlled trial on blood pressure control, the Gateway trial. We have kidney disease randomized controlled trials, our MOMS study. We have MASH resolution. Despite we still don't have level 1 evidence for cardiovascular events with surgery, we have robust data that can induce us to think that metabolic bariatric surgery may decrease cardiovascular events and mortality. But the new innovations have zero high-quality evidence that compares their operations with the hard outcomes. So first, no RCTs comparing superiority on any meaningful outcome. There's unproven superiority over medications, the gastric bypass, and the sleeve gastrectomy. And as Marco showed, there's no enhanced mechanism of action. There's no mechanism of action that was published that does not exist in the published literature of the bypass and the sleeve. There's nothing else added. We have some cautionary tales. The SASI bypass, this is a series, a prospective series from a surgeon in Libya, where he showed 20% of revision rate at 1 year because of malnutrition. We have the 20 years Francesco Papadia's paper, where at 20 years after the Scopinaro BPD, with outstanding weight loss, outstanding glycemic control, the operated group had 61% of severe complications and 27% mortality at 20 years. If you compare to the non-operated, 19% with microvascular and macrovascular complications and 13% of mortality. So it's better to be alive and not undergo to BPDDS. And now we're coming with the 50 years follow-up, they're pretty the same. So it's better to have my diabetes and have my obesity than to undergo an operation without long-term safety data. And what about the procedures that have been tested already? So there's an RCT reality check. This is the SADIES sleeve paper. Yes, there's superior weight loss when you compare to the gastric bypass, but we need to understand that 20% of total body weight loss solves the vast majority of clinical obesity complications. So 20% is a sweet spot for clinical obesity remission. But if you look at their secondary endpoint of that paper, it was diabetes control. It's the same. So if I have a greater weight loss with the trade-off of a possible malabsorptive procedure, why should I think about this when I compare to the standardized gastric bypass, regular limbs, proven, RCTs, etc.? Then we go to the Y-omega trial. Again, there's interesting data. There is similar excessive BMI loss, similar type 2 diabetes resolution, so there's not inferior weight loss and similar metabolic outcomes. However, 41% of gastroesophageal reflux disease, 8% of conversion to the gastric bypass, and loss of follow-up of 32%. And this is verbatim from the paper. The high rate of clinical gastroesophageal reflux disease after OAGB raises questions about its long-term consequences. So again, the RCTs show us that we need to balance and think on the innovations. And we have the pharma challenge. We have innovative metabolic bariatric surgery. We are debating techniques with no data. But tons of debates. I do the intestinal, the rectal, the cerebral bipartition. But I don't have any data. I rely on single-arm case series. And remember, 90% of them were introduced without any prospective registration. Look at the pharma. Tons of RCTs in JAMA, New England Journal, Lancet, etc. They move fast with rigorous evidence. They prove cardiovascular decrease in cardiovascular mortality. But we have their Achilles heel. It's adherence to treatment. So we need to explore our standardized operations that are long-lasting. We don't need to innovate. We need to really explore what we already have with robust evidence. So we need to generate and keep on generating that evidence. So where we draw the line? So this is based on the ideal framework. First, is the operation new in principles of surgical technique? Yes, this is a no-brainer. You must perform an RCT versus the standard techniques, the techniques that have proven evidence like the sleeve and the gastric bypass for safety and efficacy. If there's a claim of superiority or effectiveness on the technique, again, you must perform RCTs versus standard techniques. There's no way to prove its benefits over the standardized techniques. Is there any significant change to care or a new indication? Again, do an RCT. But always RCTs, yes, they have flaws, but they are the best evidence. It's like democracy. It's not the best way of government, but this is the best we have available. So this is the RCT. So there may be unnecessary when the procedure is not fundamentally new and makes no claims of superiority. So this is the ideal framework. And we keep on wasting our time in some conferences discussing how do I do an operation, if I do an anastomosis with staplers, with magnets, with suture, whatever we think. Look what they're doing. The pipeline of pharma is tablets with over 25% of total body weight loss in phase 2 trials already. Monthly injections with fantastic outcomes. Injections for each 3 months or each 6 months. They are doing their job and we're not doing. And let's think about volumes. Well, I do innovations because the volume of surgery will increase. Look at this. Since all the acronyms were introduced, SASI, BPT, iliotransposition, blah, 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 we're still doing less than 1% of cases. So where is the innovation here to attract more patients? If this is the goal, I want to have more patients, so I'll do a new operation. It never changed the volumes. So this is what we need to think, that we're not doing the right thing. We cannot afford unproven experimentation. This is a research that we did, Francesco and I, on behalf of Metabolic Health Institute, where in 2023, we hired a company to interview patients in North America. Over half of them were simply afraid to undergo surgery. So think if we have new operations without safety, without any proven outcomes, and most of the patients are afraid of dying for surgery, we are adding up to their fear. Any surgical innovation must demonstrate superiority or non-inferiority in RCTs versus the established standards, the one-way gastric bypass and the sleeve. This is what the Saudi sleeve did. Perfect. This is the Y omega did. Perfect. This is the way to go. And finally, science is the foundation. It's not an opinion. It's just an opinion. It's not data. So let's rethink about it and let's get back to the track. Thank you very much.
Are there any questions from the floor for Ricardo? If not, I have one. Can you comment on how the industry can give us a hand in trying to make the gray literature emerge? Because, of course, RCTs and very, very highly, how can I put it, formalized trials are excellent. But the point is that the real-world data is just as important as the RCT or the introductory trial. And there is little way to make all this gray area emerge, which is actually as important, maybe if not, than the very specific RCT asking a very distilled question. How can we have a lens, put a lens on this kind of data?
You mean what can replace an RCT?
No, I mean RCT are something. And then there is the great amount of real-world data, registry data, industry data, which is hardly accessible, but is very important to see how, in the real world, something is going. I have no idea on how we can do it, but maybe
it's hard.
With the help of industry, who knows the number, can merge and build a bridge between the two.
Yeah, real-world data is important, but sometimes, as the Women's Health Initiative or the Accord trial showed the exact opposite that what real-world data showed. Registries, yes, we can trust on them. I'm looking at Ron Lim. I know the Dutch registry, we can trust on the data there, but globally, it's hard to get data from registry. And yes, the industry could help us to identify the gaps that we have in our outcomes based on the numbers that they may have, or looking into the registries and see if we can do any network meta-analysis, and get us some data. But it's hard. It's really hard. As you don't know the answer, I don't know it either.
If I can add something, because you mentioned Ronald. Ronald is doing a great job for the European chapter concerning the fact that not only the Dutch or the SOREG registry, which are well known, to homogenize also the other European registries. But this is a project taking 5 years, am I correct, Ronald? So this is not the only way to go. The RCTs are 17 years, so we have to find out also, in the meanwhile, how to do better, let's say.
Yeah, we need to do better. Francesco.
Yeah, the question is what to do about it. So if you look at the historical perspective, you should not be surprised that in the past, there have been a lot of mishaps about procedures being developed, and then every day there was a new one, etc. There was a very rudimental understanding of obesity, and there was no competition. This is a different world. We know much more about obesity, and there are medications that are effective. When you start saying, we have to compete with other alternatives, which is a good thing to be in, giving away Roux-en-Y gastric bypass gastrectomy, the operations that have long-term proven efficacy and safety, you basically shoot yourself in the foot, because if there is a superiority of surgery, it's exactly in that long-term durability and known data. So when you hear some of this presentation about innovation, you hear gastric bypass has complications, weight regain, etc. You're communicating that that operation doesn't work in order to justify something completely new, which will not withstand the comparison with the alternatives that are now becoming standard of care. So what can professional societies do to avoid that surgery undermine itself as a field? I mean, you still see presentations that happens in professional societies. You still see industry advertising videos of new procedures. Is there a mechanism to increase the standards and the society can take a lead? What can you do to actually avoid that we undermine surgical future?
I think we lost the opportunity to refrain the reports of innovation and the claims that the gastric bypass and the sleeve gastrectomy are old techniques. We lost control of that as a federation, for example. We maybe should give opportunity to the innovators to debate with people who think that innovations are moving too fast and have an unemotional and balanced discussion. When we look at the debates, Francesco, it's emotional. It's like a soccer game. People are applauding when, oh, I did the Angrisani operation. All the supporters of the Angrisani operation will say, yes, we did the best operation. So I think we lost control. And I really don't know how to revert this and fix this backwards. But I agree with you. And the Achilles heel of medications is adherence. Most of the persons do not take medication over 2 years. And we have a long-term proven operation. So we keep on shooting ourselves. That's the point. I really don't know how to go back. If somebody has an idea, please let us know, because I don't know how to go back and fix this.
On the other hand, can you think that our colleagues doing oncologic procedures criticize the mortality or the morbidity as we do for our procedures? This is a masochistic vision we have. And you're right, we should revert the situation. But
it's tough to revert. To get back, we lost control. It's unleashed.
Other comments? Please. Giuseppe Marinari.
It's just a comment. I'm quite old, 65. So I was here 35 years ago listening to all the Congress and so on.
Sorry, Giuseppe, not everybody in the room know that you are experienced as Francesco,
okay.
living with Nicola Scopinaro for long.
Yeah,
so
yes.
This is for the younger people.
Thank you. What I think is that what we are missing, 20 years ago, science was telling us, we were surgeons, not a good idea, and science was telling us that people should have lost their weight, improving physical activity, going on diet, and so on. We had a very short period of our history in which surgery has been a true pillar of the therapy against obesity, and now we are moving out because there are industries and so on. What we miss, in my opinion, is always the opinion of the patient. I don't want to say that we need to have here representatives or association of patients and so on, but we should always remember that very often are so many operations and so many differences and so on. Maybe it has been driven by the patient opinion. They are looking for something that should be absolutely safe, absolutely fast, absolutely affordable. And so now they are looking at the pharma because they are avoiding surgery. I mean, obviously, we must talk about science, but we should always remember that in oncological surgery today, there are people that are refusing therapies because they don't want a stoma, let's say, and they prefer to die, maybe in 5 years, but with a different quality of life. And we are never talking about that. It's very difficult to assess quality of life, for sure, but we should have that in mind now and then, because they are driving our shoes. They are driving because patients are driving very often our choice. We can talk about them, we can talk with them about science, but if we talk with them just about science, maybe we will fail and we will be far and farther less the possibility of curing obesity. That's my opinion.
Yeah, but if you go to an emergency room with a myocardial infarction, the patient will not say, I don't want a stent, I want a pill. But the right way to save his life or her life is to give a stent. Nobody will argue in the emergency room in cardiology that, no, you're wrong, I want a pill because I'd rather have the pill. No, we are the experts. We can show them in a very pedestrian language that this operation is better than that one because this or that is safe and effective. So giving the patient the opportunity to choose what they want, I'm not saying medications versus surgery, but between surgical techniques, I don't think it's the best way to go because patients may be influenced by what they saw on Instagram, a doctor dancing and saying that if I have an ear to the ilium diversion is the best operation. So they come and say, hey, Dr. Marinari, I want to undergo the ear to the ilium diversion. So, and then you say, no, because this and that. So we need to merge
Yes, for
everything.
sure. We have to merge, but both, I think.
I think you hit the nail, Ricardo. The problem is the original sin, if I can define it this way, of bariatric surgery, is that it was named weight loss surgery.
Yeah.
The problem is weight loss, it's something that people will always look for the simplest, safest, fastest procedure, and because it's a prophylactic intervention, it's conceived as a prophylactic intervention. Surgery for prophylaxis, even when people have BRCA2 genes and have 70-80% of developing a cancer in their lifetime, they elect not to have mastectomy. 80% of women don't want to have the mastectomy, even if they know they have 80% chances of cancer. Because surgery to fix a problem that doesn't yet exist doesn't make sense to most patients. Only to some. And those are the 1% we have seen historically.
Yep.
So we need to do what surgery does best in every other field. We need to use surgery primarily to treat disease, occasionally as a prophylactic intervention. If we are able to turn that around, maybe surgery is there to survive. If you have to be prophylactically, there are competitors out there that work much better than this.
Again, we missed the opportunity already. We need to go backwards. It's a very hard mission. Nicola.
So, other comments, questions? If not, it's time to close this session. But I would like to spend a couple of words on this. First of all, we are so happy to have in such a theoretical session so many people interested. We were looking at the audience, everybody was interested. So it's very nice, and we had to thank very much the scientific committee, Marco Buter, and especially, I think, Francesco Papadia for building up this session. And what do you suggested to have more discussion with the creator of new procedures could be another way to go ahead. I know that's a sort of soccer match, but it could be an option for the future. Thank you everyone for being here, and let's have a clap.